Good evening, everyone. I'm Elizabeth Saywick, the Associate Director of Research and Teaching Scholarship at the School of Nursing, and I'd like to welcome you all to the Marion Woodward Lecture. Before we get started, there are the usual housekeeping things. Restrooms are directly out and to your right. Hopefully there will be no fire alarms. After the event, we will have a reception. But before that point, we would like you to stay tuned. We will actually have a prize draw from our alumni engagement and UBC to actually provide some prizes. So those of you who put your name tags in the vase will actually have an opportunity to win a bottle of wine or a few other nice things. So we'll do that immediately after the presentation and the dialogue before the reception. Unlike most events, given that our focus and theme this time is on nurses' roles in health information technology, we don't want you to shut off your phone. We do, however, want you to set it to buzz or silent or whatever way you want to, but feel free to tweet or Facebook throughout the event, hashtag MWL2015. But do make sure that it's not emitting any sounds or sirens or what have you. So we have a wonderful Marion Woodward lecture scheduled. But first, I'd like to introduce the Dean of the Faculty of Applied Science, Dr. Mark Parlange, who will come to say a few words of welcome.
Thank you very much, Elizabeth. It's great to be here this evening. I think this is a very special occasion. I just wanted, as you see, we have our poster here, and this is the centennial of the university. In 1915, we admitted our first students, and in 1916, we actually graduated the first class. So apparently, I don't know if they were smarter or if things were easier, but they could go fast in those days. And so that was very special. What's very special is actually the Faculty of Applied Science was one of the founding faculties. And as I always remind people, the School of Nursing, which is part of the Faculty of Applied Science, is actually the oldest program of nursing in the British Empire. It's actually, Sally Thorne reminds me of that. So I don't know if Sally, if you're out there. Oh. So it's quite special. There's a number of things exciting things that have been going on this past year, and many of you have been working very hard on the Masters of Health Leadership and Policy, and so we're very excited to be welcoming the first class this coming January. So, and I'd be happy to talk more about it. But I think this coming year is going to be a special year. There's for nursing on November 19th. There's going to be a history occasion to look at the history of nursing at UBC, and so I hope that many of you will be able to come out for that. And in the spirit of this anniversary, we have a short film, and I don't know if I'm supposed to push. Nope. Push out of the way.
That's my job.
There are few earthly things more beautiful and splendid than a university. There are few universities that can claim to have grown to the stature of UBC in some...
You're supposed to use the force and just see it by all that kind of stuff.
There are few earthly things more beautiful and splendid than a university. There are few universities that can claim to have grown to the stature of UBC in such a short span of time.
It is the unique privilege of the University of British Columbia to be located where one of the world's most important traditions began and flowered.
At this significant milestone, we should acknowledge and praise those who founded the university.
You accepted traditions and became part of traditions.
Every last citizen is, in fact, a part owner. And this is without doubt what the founders had in mind when they chose for the university motto, Quum Est, it is yours.
It is a place where those who hate ignorance may strive to know, where those who perceive truth may strive to make others see.
That we may indeed be the People's University, that is the spirit on which this university was founded, and it still lives and survives on this great campus today.
Thank you.
Thank you very much.
Technology, isn't it wonderful? And now I'd like to introduce our school's director, Dr. Suzanne Campbell, who will also say a few words of welcome.
Welcome all. How wonderful to see such a full room. We've had an afternoon of exciting dialogue, and we're here to continue. Thank you, Dean Perlange, for being here with us this evening. We have many special guests in the audience, and you stole the thunder a little because I was going to start with, established in 1919, UBC School of Nursing has almost 100 years, we're almost there, of experience educating nursing leaders throughout the province and innovating research. The UBC School of Nursing is the home to the first degree program, so that is the university-based degree program in nursing in the Commonwealth, and was one of the first academic programs established at UBC after the university's inception in 1915. Our founding director, Ethel Johns, an internationally recognized educator, public health nurse, researcher, writer, and advocate for social justice. Her insistence on a baccalaureate-level nursing program led to the establishment of the first university degree for nurses in the Commonwealth, and 4 of those nurses graduated in the school's first baccalaureate class. Today, 120 men and women annually enter our program, and in 2019, we will celebrate our 100th anniversary, recognizing a century of preparing nurses for careers in professional practice, education, and research, which make our communities healthier and safer and stronger. The Mr. and Mrs. P.A. Woodward Foundation has generously supported this annual Marion Woodward Lecture since 1969. This lectureship marked the first time that Marion Woodward had allowed her name to be used in conjunction with any of the beneficiaries of the foundation. She hosted a tea in her home in honor of the inaugural lecture given by Dr. Helen K. Musalam. Mrs. Woodward was able to attend the first lecture in the series before passing away the following year. We're very grateful to her that this tradition has continued to bring our community partners together, our nursing students, faculty, researchers, and leaders throughout the province, as well as many of our health professional interdisciplinary colleagues. So at this time, I just want to say a more general thanks to all of those of you who support us, our many donors, alumni, and friends of the school, and I thank you for being here to share in this very exciting evening. Thanks so much.
Thank you, Suzanne. It's my privilege to be able to introduce this year's Marion Woodward Lecturer. Dr. Robyn Tamblyn is a professor in the Department of Medicine and the Department of Epidemiology and Biostatistics at McGill University. She's a James McGill Chair, a medical scientist at McGill University Health Center Research Institute, and the scientific director of the Clinical and Health Informatics Research Group at McGill. As of January 2011, she also became the scientific director at the Institute of Health Services and Policy Research at the Canadian Institutes of Health Research. Her groundbreaking research on educational outcomes has elucidated really important relationships between health professional training, licensure, and practice that have subsequently guided credentialing policies. Her work on prescription drug use, its determinants, and computerized interventions to improve drug safety have been recognized internationally. She leads a CIHR-funded team to investigate the use of e-health technologies to support integrated care for chronic disease, and co-leads the Canadian Foundation for Innovation Informatics Laboratory to create advanced technologies to monitor adverse events in populations and to create new tools to improve the safety and effectiveness of healthcare. Her work is published widely, of course, in the Journal of the American Medical Association, the Annals of Internal Medicine, the British Medical Journal, Medical Care, Health Services Research, among others. She's been awarded the CHSRF KT Award for her research in improving the use of medication, as well as the ACFAS Bombardier Award for innovation in the development of a computerized drug management system. Please join me in welcoming Dr. Robyn Tamblyn.
Really may not make it. I may have another gentleman's problem like you have. So I have to say it's a true privilege to be here. I looked at the people who had provided this lecture over the many years that it's been provided, and I'm very honored to be invited to be part of this very long tradition. So it's with privilege that I actually changed the title a little bit, because I thought, I think what we need to look at is information technologies as enablers of how to get a system in Canada that we've actually cherished to move forward into a new era. And I see this as maybe not quite a disruptive technology, but as one that can assist us in transforming the way we deliver care. And with that in mind, in fact, I want to just give you a little bit of context of where we're at. So Canada, like many other nations, has experienced a rapid growth in healthcare expenditure. Only part of this is explained by an aging population. The only country that outstrips us in terms of per capita cost is the United States, but we are well in the bunch of becoming quickly unsustainable health spending to provide health care. And if we look at what's contributing to this expenditure, it is really the increase in new technologies and broader coverage, which is, if anything, still shortchanging our aging senior population, where we're not providing home care, we're not providing pharmacare, or at least we're doing it in a very patchwork way, and we're not supporting long-term care. So we're in trouble. And other countries have been in trouble as well. I just want to give you an example of what happened in Britain. And in Britain, actually, they said, we're in trouble, and we've got to change the way we do business because our health care is really sinking into a morass of poor quality care. And we're having a growing private sector to deal with that. And so we're going to actually reform very dramatically the way we do business, and we're going to start paying for quality in healthcare. And as a result of that, in fact, they actually have produced not only better outcomes, but they've achieved a slower rate of growth and better outcomes in the process. So if we had done that way back when they did that, in fact, we could have saved $659 billion over the last 15 years or so. And what could we have done with that? And I think this is the issue. What could we have done with that? Well, we could have actually provided child daycare for $5 a day for quite a considerable number of 14.6 million children. Or we could have sent students to university for 4 years, spending for $23.5 million. We could have actually sent that many students to university free of charge, which became a big issue, by the way, in Quebec, where we had the pots and pans parade over tuition increases. Finally, we could have built over 9,000 Trans-Canada highways. So there's lots we could have done with that money. So the issue here is how can we embrace the digital age, and how will that help us? And can we be very strategic about this? There's a great way of actually blowing a lot of your cash is on digital healthcare, and we can look to a couple of countries have done just that, and maybe we're even in the same basket. But if we are smart and we are strategic, and if we drive this to say we need to actually change the way we deliver care, then I think it's possible for us to actually spend wisely, strategically, and if we're going to do that, that we need to have clinical leadership in the middle of the tent actually driving what it is that we need to change. So I just thought I'd give you an example, because I'm very much a sort of problem-oriented thinker when it comes to health care, nursing care, and health services research. I do believe that we should actually find out where the problems are and try to fix them. And with that in mind, I thought I'd give you an example and actually weave the story of what we can do around the patient journey. And so I'm going to give you an example of a patient journey. It's Madame Blanc. No, it isn't the Mrs. White that was found with a candlestick in the living room, but it is, you know, the French version of Mrs. White. And so this is your classic patient, I think, that most of us will see every other day, which is someone who is, you know, older and has quite a number of health problems. And in our system, essentially, if you have something that goes wrong with you on the weekend, is you go to a walk-in clinic. And I know you have plenty here in British Columbia. And in this particular instance, this is a woman who had a repeated urinary tract infection. She went there and she picked up a prescription for Cipro. She then went off to see her cardiologist, who was managing her cardiac problems, and he provided her usual plate full of prescriptions for that. And then she finally got her appointment to see her rheumatologist, who proceeded to prescribe her with Vioxx, which, by the way, was considered to be almost lethal for cardiovascular problems and was taken off the market. And so the issue is this. What's going on in this story? Well, for sure, we've got a situation, we've got very fragmented management of patients with complex, multiple illnesses. And in fact, when we look at what's ahead of us in Canada, we can see that multimorbidity is on the rise because everybody's living longer, and as you live longer, in fact, you're much more likely to have chronic conditions. And so this is the new reality. It's not we're treating asthma, we're treating cardiac disease. We're treating people with multiple different health problems, and we need to get better at it, and we need to transform our the way we deliver health care to do it better. So if we want to say, are we doing well? Well, Canada, we've always prided ourselves in having a fantastic healthcare system, and I was just talking to people in Taiwan who basically said, well, we modeled our healthcare system after Canada because Canada was the best in the world, you know, at that point in time. We didn't mention at that point in time. So the Commonwealth Survey has been doing, Commonwealth Fund has been doing surveys in many countries, and Canada, unfortunately, has been sort of at the bottom of the leaderboard. If it wasn't for the United States, we would be at the bottom of the leaderboard, so thank goodness for them. But we are definitely not doing well. And we're not doing well because we're not able to manage chronic conditions well, and because our system is not set up to do it. Who in heck would think you should go to the emergency room to get your hypertension prescriptions refilled? This is not what you should be doing. So when we look at that, we say, okay, well, what's going on? Well, you can look at the canary in the coal mine, the very complex patients like Madame Blanc. And, you know, people like her, they're responsible for about 50% of health expenditure. So if we can fix this problem, if we can actually go after this, then we can probably make changes that are fundamental that will change the way we deliver care for the great masses. Now, fortunately, Wagner basically provided a nice chronic disease management model. I'm sure you're all very familiar with this, which says if we want to do this well, we have to reorganize the way our systems deliver care. We need to provide decision support, and we need to have clinical information systems. So right off the bat, you actually have to have an information infrastructure to make this work. You can't make it work without it. And you need, that information infrastructure has to deliver on decision support systems and support your care redesign objectives so you can get where you want to be. And of course, the next thing you need is you need the community to be engaged in and particular patients in self-management. And of course, you need an activated patient, and you need a proactive, I say, team. Doesn't wait for the crisis to happen, but they're ahead of the game. And one thing that actually is true in terms of solutions, and let's just move to solutions, is nursing case management systems. I mean, this is now, I'd have to say, become tried and true. Nurse case managers are the band-aids that manage to deal with the fragmented system that we have. And in fact, when it comes to chronic disease, you need someone like that. You need someone who actually can help you navigate through the healthcare system. And information technologies can enable that, not just in bringing all the information you need to get it for that nurse case manager, but allowing them to actually keep track of patients who are in trouble and need to have problems solved. And when those systems have been put in place, essentially with the information feeds, you can see this is an example of the Massachusetts system, is that there is actually a mortality benefit. In fact, nurse case managers actually save lives. This is bottom line. And so they don't probably just save lives, they probably save money as well, but everybody seems to be concerned about saving lives right at the moment. But when you ask whether or not it improves, you ask physicians, you ask nurses, does this improve how care is delivered? The answer is, well, yes. They think it improves not only the efficiency of care, but of the quality of care that's delivered. So I think this is a no-brainer for us. This is where we should be going. This is really going to be one of the most important keys in this journey. So if we take a look at continuing on the story of Madame Blanc, basically she's now got in a situation, she's got multiple prescriptions from multiple different physicians. No one knows about each other. And basically she does what most patients do, is they put them, she puts pills into a bottle because she has a small purse. She can't carry around that entire truckload of medication in all the bottles. So she puts them in her purse. And what's unrecognized here is that there is an interaction between her Cipro and the fact that she's on her warfarin or her Coumadin. And as a result of that, she actually develops symptoms of a stroke, is rushed to the hospital, where she's seen by the triage nurse, who basically says, I wonder what medication she's on. The triage nurse calls the pharmacy, and the pharmacy says, well, I don't really know, and the only thing we dispense for her, because she went to 3 different pharmacies, is this drug. So no one really knows at this point what she's on, and she's unconscious. So life moves on for her. And now we look at the issue of how can we start to try to deal with this. As you've already heard, of course, this has been a bit of a preoccupation of mine, mainly because it's such a mess. It is just a mess. The prescription drug management piece is the most deplorable thing I've seen. And if you look at the problems here, we've got 2.5 million hospitalizations in Canada each year, and of those, 19 to 23% of discharged patients will have adverse events within 30 days. Within that, 14.3% of them are going to be readmitted, and about 2/3 of those are going to be related to prescribed medication. And not surprising, people go in and out of hospital because things aren't working well for them, they get their medication changed, no one follows up, blah, 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 we get into real trouble. So if you look at it, and the cost of that is about $2.6 billion a year. Now, that's not much in a $220 billion budget, but this is just talking about the actual cost of hospitalization, not the cost to human life and misery. So if we look at, opportunities to prevent, well, there seems to be a lot. Well, a couple of things. One, when patients tell their clinicians about their symptoms, they're ignored. And so drugs aren't changed when they should be, when they're having trouble. And most people don't want to talk about that anyway. They don't want to admit that they actually just abandoned that treatment because it wasn't working too terribly well. So there is an opportunity here for prevention. And if we look at the issue of multiple prescribers, you can see that once you start getting multiple prescribers in the system, all hell breaks loose because you have no way of actually knowing what everybody's doing. And in fact, sadly, because of the fragmented care we have and the fact for complex patients, they're going to see many different people, is the vast majority of patients have more than one prescribing physician. And now we have pharmacists also prescribing, and maybe nurse practitioners also prescribing. So now everybody's in the mix prescribing, not knowing what each other is doing. So I think part of the solution here has got to be that we have to have a shareable. We talked about this at dinner. I think we talked about it a little bit earlier in the afternoon. We need to have a shareable electronic health record. And we need to actually have alerts so we don't have to get people to memorize a compendium of 360,000 drug interactions. Let's forget that plan. And say we need computers to do this for us because it's information overload. And so we need to get that done. Now, one thing that has really excited me is the fact that Canada, courtesy of Infoway and the provincial investment, has created drug repositories of all drugs, all people, in each and every jurisdiction. Now, in our jurisdiction, no one has access to it because you have to have a complicated key arrangement, yada, 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 so we don't actually have access to this. But in theory, in fact, this information all is in a repository, and BC was the first in 1996 to actually put one of these in place, made it available only to pharmacists. The physicians had to, and ER team had to actually go almost to court to get access to the PharmaNet repository. tails out of school. But anyway, the bottom line was this is fantastic information, because that means at the moment of care, you can actually pull up what that person has been dispensed so you can take a look at it. So I don't know if anybody in this audience, I'm sure you all have had experience with this and have been able to access this, but this is a phenomenal resource that no other country really in the world has been able to do this. So this is a phenomenal opportunity. And so that means that you can actually pull up, and here's an example of pulling up and looking at someone's drug profile. You can look at the drugs that are prescribed by different people. You can look at how many pharmacies are involved. You can look at drugs that are prescribed that were never dispensed. No wonder this person's not getting better. They never filled their prescription. And so when we've tested this, we actually provided this as have the last decade in an ongoing sort of research program in Quebec, is that we found that clinicians access this drug profile in primary care, both nurses and physicians who are involved there. And it was really interesting because they accessed it for people. So the highest income people were less likely to have access. So they accessed it for the obvious, right? When people are on multiple medications, they want to know what they're on, and when they're lower income. So this is a disequity equilibrium that's being created through information technology. Everybody worries that it will increase inequities in healthcare because maybe some will have and some will not have computers, but the bottom line is this, is that information that is much more accessible for high-risk, fragile, complex populations, that's where the money is and that's where people go because they know they're harder to manage. So I think this was really very good news. But let me move on to worse news. So the worst news is this. So, you know, we've got a whole industry going on in what I'd have to say drug knowledge systems. So First Data Bank system is the biggest in Canada, but there are a bunch of others. And the bottom line here is that they assemble every possible drug interaction on the planet, and essentially they drive those down and they send out, they link those with prescribing systems and so on, and they send out alerts. Every hospital in this province will have one of these systems, and it will have alerts on prescriptions, and every community pharmacy in this province will have one. And what happens is there's a whole new industry called turn the alerts off. The reason is because there are so many alerts. And so you could see here in this particular software design, people had the choice of turning alerts off. And it became a sort of make-work project. Let's turn those alerts off. And the difficulty is that people didn't know how risky that was. And so when we ran a trial, we said, okay, well, let's look at on-demand. You asked for it when you wanted it, versus we'll push it to you no matter whether you want it or not, which is how most systems are designed. Because the reality is for every one patient, they have about 4 different alerts. And in the on-demand group, of the 4,445 alerts that were present for that 1,550 patients, the on-demand group saw 40 of them, meaning because they didn't want to know, and when they wanted to know, they actually did do something. So they suspected something was wrong, they did something. But of the group that actually had it pushed to them, is they quickly turned off a whole bunch of levels, and they only saw 650 of them, or 670. And they were less likely to actually respond to them. So what's the future for this? I mean, this is really not something we want to do. And I think as anybody who's a nurse in the room has probably been in a situation where there's machines that are alerting you all the time, right? And so there is this alert fatigue that goes on. So we have to get smarter. This is a dumb knowledge system. It just says, I'm going to take everything that's in a book and I put it online and I'm just going to alert the shit out of you. So we need something better, and so this is where I think there will be data science meets clinical care. So we use the data that we have to start generating predictions of risk, predictions of benefit. So here's a prediction of risk of a person who is at risk of having, we want to produce a risk of injury as it relates to the use of psychotropic medication with CNS side effects. So we actually built a model on 460,000 people. We have big data, so we did that. And we produced this, which is sort of a system that says, the green area, this is their risk, you can't do anything about it, their age, their cognitive impairment, blah, blah, blah. And all the red stuff is related to their drugs. And so we built that on a very ugly looking algorithm. I mean, this is a specialty of epidemiologists. They love to do things that no one else understands. And so we actually built that, and it was ugly, and we hid that all behind the scenes, and that's what produces that thermometer. It takes what drugs you're on, it says the risk attached to those, it produces that. And so the cool thing about this is that you can actually provide people with real-time feedback. So as they change their mind about what they're going to do, you can say you're either increasing the risk or you're decreasing the risk. and actually give that rate to them in the face, they can make a decision about that. So it's a learning tool, but it's also a personalized, I guess you'd call it precision healthcare, or precision prescribing. So even in looking at that, actually, we managed to, for high-risk patients in particular, people paid attention, and they actually reduced the dose. That was the simple message: reduce the dose or don't prescribe that drug. So I think there's huge opportunity here. We should see much more of this. This is going to be exciting for us because it's going to help us to predict things before they happen, and we can intervene earlier. Another thing which I think has been really very interesting is the opportunity to use. Now, I'm not sure that I would want to talk about this right at the second, but I'm going to. So interactive voice recording systems. I don't know if you know this, but these are the idiot people who call you up on your phone and give you a voice message, right? Okay, well, I think that maybe the whole industry has probably spoiled it for healthcare. But we want to use this kind of a system to have more timely detection for people who are in trouble. So we used it to essentially, one person got a new medication, is that we actually said, well, let's enroll them in this program and there will be a call up. And this is like an automated triage program. Think about it that way, is it's electronic triage. And you could see that this can be very useful in a whole variety of circumstances. So do you need to see everybody 2 weeks? No, probably not. What you need to see is the people who are in trouble. So call them at a time, 3 days after, 10 days after they would have probably started. And so using that kind of system. And when there was a person who was identified as having a problem, it was triaged to a nurse who basically intervened, called the person, and managed through that. And what's fascinating about this is that for this particular situation is that we had essentially half the people had some kind of problem in the first 30 days. And of those people that had a problem, about 25% of them, it was an adverse drug event. Some of them didn't fill the prescription because either they didn't think they should have, or they misunderstood, or they couldn't afford it, or whatever. And others just wanted some advice or some sort of problem solving. So this is great because instead of following up that full 100 people, what you've done is you've identified the 50 that are having a problem, and now you can actually intervene in a timely way. Now, this particular nurse went to Germany during the trial, which is really annoying, to say the least. But she actually managed from Germany all these people. So it's possible to be anywhere, and that means you can take the best person in the field or the best people in the field, and you can put them right at the right time to the right place to the right person. And I think this is what's going to make it really fun, I think, to be a professional again. And in fact, you can take that information that comes out of that dialogue they've had, and you can send it back to the desktop, to the dashboard of the care team, and say, this is what's happening, by the way, with this person, and this is what I've done to solve it. So if we carry on in our journey with Madame Blanc, basically, she gets in hospital, she spends a week in the internal medicine unit, and she ends up by having a double dose of her antihypertensive medication. People shift change, confusion, it was a given, was it not given, so she ends up by getting a double dose. She gets hypertensive, she falls out of bed, she breaks her hip. And so let's take a look at that. Are there solutions for that? So there's been really some great things that have been done in terms of improper medications administered. And if we take a look at how often this is happening, it's about 3.5 incidents per 100,000 medications. Not surprising, actually. There's a lot going on, especially in hospitals, a lot going on. And it results in essentially 1 death per day, or 1.3 million injuries per year in the United States. So this is a big number. And it's essentially one of the, I'd say, largest preventable causes of injury. And I think anybody who's been in this and knows how busy this becomes and how easy it is to get it wrong. So solutions have been created, and I think this is another solution-oriented big problem, needs a solution. So electronic medication administration has become growingly the norm in acute care facilities, which I think is very exciting, because if you take a look at what happens when you start putting that in place, the red line is medication error rates, the blue line is before EMARS, and the red line is after EMARS. So phenomenal decrease in the number of errors. And if in fact, if you barcode, it is even faster and more efficient. So the good news about this is even with manual data entry, it's great, But with barcoding, where you don't even have to have any manual data entry, it's even more phenomenal and eliminates the documentation requirements. So you can see that it happens that it can be reduced at ordering, where about 67% reduction with barcoding, to administration, where there's a 51% reduction. So this is really a sure winner. We should have done this a long time ago. You know, we did unit-based dispensing or unit dosing, but this is a clear winner for everybody, and actually saves not just lives, but saves a lot of cost. So continuing on in our journey, where she breaks her hip and she basically gets sent to orthopedics, where she has surgery, and there was some confusion in the transfer, and they actually sent the original list of medication and not the one that she was really on. And so as a result, when they went to write the discharge prescription, they ended up by putting her back on her Coumadin when she shouldn't have been on the Coumadin because she had a hemorrhagic stroke. And so not only that, but the prescription was illegible. And so the pharmacist basically doubled the dose of Coumadin above and beyond what was there before. And needless to say, she's back in the hospital again. So are there ways of preventing this? And I think the answer is yes. So the problem here is nursing workload. It's massive and getting worse, I'd have to say. The number of hours per day a nurse spends with a patient is about 8 hours a day. And if we look at what they're doing, in fact, they're doing medication administration for 36% of the time. Well, good Lord. In fact, we could actually use that EMR system like right away. That should be a burning issue in our country. And they're spending 7% on documentation and only 19% in patient care. A lot of stuff in care coordination because of our broken up system. So a lot of calling you have to make to actually organize things. So needless to say, there's a lot going on in the life of a busy nurse in the hospital this day and age. So if we look at how we can actually improve things, we've got devices and technology that are really interesting. And if we look at nursing documentation and how it's trying to actually computerize documentation, the good news about that is nurses gain, physicians lose. So the time spent in documentation when it's computerized is much less for nursing than it is for physicians who have to spend more time. So this is great news, is to actually try to computerize some of that documentation, which I understand is a new initiative in this province. Very exciting. The second thing I think that just blew me away was 2 Israeli guys, a couple of asthmatic kids, they're trying to figure out a way of actually detecting non-invasively when people were falling apart. That means their kids at home at night. They built something that basically went under their bed, which was a sensor, non-invasive sensor, that monitored their breathing, their heart rate, and this and that, right? No business model at all for this. That didn't work, but it was suddenly the solution for in-hospital environments where you're not in the intensive care unit. You actually got single rooms, which are great for infection control, and you've got the problem of one nurse circulating around 36 beds, which is the problem with the woman. So they actually built this thing. I'm sure these guys will be billionaires at some point in time, and actually embedded it into the bed springs, basically, of the beds, and actually provided essentially a dashboard at the patient bed and at the nursing station to see everything that was going on with everybody. So cool. And as a result of that, there are many randomized trials that were done. This is one that was done in the United States, basically showing that code blue events went from 2.1 to 0.9, fantastic, and that the days per 1,000 patients went from 85 to 63. ICU length of stay reduced because fewer people were in the intensive care unit. So really phenomenal, and I think this is the beginning of all sorts of things that can be done. But I think this one's really exciting. And finally, when it comes to hospital unit transfers, of course, there are lots of issues here. Adverse events related to patient transfers are often related. Here's I think this is I can't remember which state, Massachusetts, I think. Essentially, their reporting system for adverse events is basically showed that most of it was communication, then there were issues related to intravenous lines and tubes that were improperly managed during the transfer, and then monitoring techniques. So how do you improve communication? Well, there are a number of solutions. One is to use more standard, train people using a mnemonic, and this was published in the England Journal, because they were from Boston, no griping there. Anyway, so use a mnemonic and train and sustain people. So that's okay, but that's not as sustainable. Here's another solution, and we had a discussion of adoption earlier. It was called VSI in the Flow, which allows you to see what's going on, and Flow allows you to message. It's like a tweeting program amongst the care team. That's kind of the way I think about it. So, you know, as you have something, it tweets to other members of the care team, and you can push the tweet to everybody or just to a particular person. And you can use that for sign-off, and you can use it for discharge notes, you can use it for documentation, and you can use it for handoff documents. So this was a BYOD. Anybody know what BYOD is? Bring your own device. Okay, so this is a bring your own device. You brought your own cell phone. And in fact, this was available. They didn't do any training. They didn't do any advertising. In the first 6 months, they had 765 users. And more begging to lock in, load on. It was very easy to use. And it produced this kind of a handoff report. So when they tried it out, let's say in the intensive care unit, you can see this is one of those social network diagrams, which is a postdoc of mine actually did this. I don't even know how to do these things. But in any way, you can see that there's a lot of players involved. And those players, which represent residents, physicians, medical students, nurses, and others, you can see, you know, that this facilitated communication amongst the team, even in the intensive care unit, which is kind of a closed environment, to say the least. But people are all over the hospital and come back and forth. So it's a very cool tool. Now I'm going to have patients to the whole thing, which is kind of fun. And then consider experimenting with that after discharge and actually using it that way to support the virtual care team that's in the community. So pretty exciting. So there's lots of things out there that I think are coming our way. In terms of transitions in care, we know that there are issues at discharge. Anybody who's been here for any length of time, a couple of weeks, will realize that there are problems. Anybody who has someone that's in their family that's just been discharged from hospital also knows there are problems. And in fact, so in terms of care transition medication errors, this is a huge issue. It accounts for lots and lots of adverse events, many of which are preventable. I won't read through this. You can read it yourself. But and that's led to Accreditation Canada and JCO in the United States basically saying, thou must do medication reconciliation. That's a requirement. Everybody has to have it. And by 2018, every person admitted, transferred to discharge has to have medication reconciliation done. Big job. I don't know how many here have been involved in this, but it is time intensive, labor intensive to do it. So are there solutions? And in fact, I think there are. A computerized assisted medication reconciliation. So this way you take those lovely repositories, Pharmanet, and you go suck the data out of there and you just pre-populate the community drug list so that you already have it already. You don't have to have people re-entering it. You know, in our hospital, 5 different people take 5 different medication histories and they enter it on paper, for God's sakes. You know, so this was a lightning bolt to them. Oh, we can just retrieve it. You know, one click and you can retrieve this kind of stuff. And then you can actually retrieve the information from the hospital and you can line it up so you can see what was in the community, you can see what was in the hospital. You have to have a whole bunch of rules about this, but nevertheless, you can actually line it up and you can just see what you want to do. You can see the things that are missed and that you should maybe prescribe in the hospital. And you can actually manage the discharge prescription this way. And moreover, when you decide you're going to change stuff, you can actually ask for people to comment on why it is that they're changing, essentially stopping or modifying medication, so you can actually communicate that back out to the community so that they don't re-prescribe it, like the Coumadin re-prescribing for her hemorrhagic stroke. In any event, so in fact you can actually turn that into a typed, legible, I modified this, I stopped this for this reason, I changed this, I'm continuing this, I'm doing this new stuff. So this is all possible to facilitate communication during the transitions. Ideally, these kind of things, and I don't know this would happen in your Connect Care, can actually be transferred directly out to the medical records in the community. That's what it should happen. Right now we're using the fax machine as a mechanism of doing that. But the good news about that is for medications that are stopped where no one's ever communicating about those, is in fact it actually is seeming to be working in reducing the number of medications that are stopped that are continued. So of those that are stopped in normal, usual care, about 15% of them are going to be re-dispensed to probably great harm, which I'll tell you about later, should we ever finish this trial with me staying mentally intact. So I just want to finish up with a few things, and that is, like, what about community care? I've talked a lot about hospital care. I think hospital care is where we have a lot of opportunity to make some changes, but to me the most exciting thing is in community care. So I'll just give you Mr. Smith. And Mr. Smith, the whole issue here is you've got people in rural or remote or inaccessible. They're having trouble getting in. They want to come into the downtown area to go to the hospital, find parking, yada, yada, yada. Because we can do this differently. And I think we all know we have an aging population. I don't need to tell you that. And so the thing that I think is going to be, and we came up this afternoon, is online health care. We're going to be empowering consumers to start taking care of their health. And we're going to be able to biosense, biomonitor, you name it, we're going to be able to do it. So we talked about patient portals as a way of going. This is a trial that was done both in asthma and COPD. So it was allowed essentially exchanges between nurse case managers who manage patients and what was going on in the community, so that there can be a two-way exchange between people. It doesn't really work if people are just entering their data. It's the compulsive well that enter their data religiously in some sort of document. So the people who really want to have input, they enter their data because they know someone will look at it. And they feel secure. So qualitatively, they feel more secure because someone's watching. Someone's watching what's going on, and they're excited about the fact that if they get into trouble, someone will step in. And nurses, we can organize their care. So here are some people who are in the red zone because things are going on. You need to call them first. Let's organize your day so you can hit the people who it will really matter. And you can actually highlight and deliver action plans. We call the precision message from nursing. You know, here you go. This is what you should be doing. And really very cool is that actually when this kind of a telemonitoring kind of system was set up to replace home care visits, it was evaluated not by us, by a crew over at U of M, is in fact they ran a randomized trial, and the good news about this is that it actually reduced the cost of care by $1,000 per patient, which is just amazing, amazing. And it wasn't because the nurses weren't driving out their cars to the homes. It was because they could provide much more timely intervention, reducing ER visits, need to go to the ER, and hospital admissions. So that's exciting. So what about the future? The future is very cool. So we're going to get into robotics. We're going to get into virtual presence. So Finland, this little thing in the top there, that's something called the kangaroo, and it allows nurses to make home visits. So the nurse is visually in that thing, and it travels around your home to find you, to talk to you, right? So it's kind of cool. Colleagues of mine said, I don't think this is going to work with my mother with cognitive impairment. Who knows what she'll think about that? But it is exciting what's happening. And there's more and more happening every day. And in fact, of course, Google is creating a contact lens that will have everything possibly measured in that, so you can just transmit that by Blu-ray. And of course, we have robots now being actively developed in Japan, actually, to manage and support people who have dementia in their homes. So who knows where this is going to go? But what do we think about, what are the implications here for nursing? And I just want to wrap up on that. So I think there's no doubt technology-supported health service delivery is in the future. It may not be the best thing you've ever seen since sliced bread, but I think there's a role here for people in this audience to play in actually leading the challenge of let's get strategic, let's get problem-oriented, let's solve the things that we want to have solved, and not buy just a standard box that isn't going to really address the issues. It should allow more timely intervention by expert nurses through smart monitoring and virtual presence. I think that should be, and that I think will be a real boon to professional autonomy and just bloody interest in their job. It should reduce administrative drudgery. When I think the number of forms that are filled out, the number of forms I fill out, writing in my name every time, even though the computer knows my name, unbelievable. And it should provide really great opportunities for research and training. But I think avoiding the high promise, low value technology is critical, and I think we've seen a lot of that. People buying stuff, they very simplistically think there's a silver bullet that's going to solve all my problems, and let's just go buy that. We talked about that earlier today. What's it going to take to make sure we avoid that problem, because we have it in spades. And I think to avoid it, we need co-innovation between nursing and IT vendors. I don't think it's going to happen any other way. This whole field's too complex. You know, no one's going to understand it except the people at the front line. So you need to be in the tent, in the shop that's co-inventing these new solutions if you want to get what I think is possible. And to do that, I think probably, if it isn't there already, I think we need a new specialty, which is informatics nurses, and I think the group here is well on its way to creating that, a little hybrid. for us, and I think that's what we'll need to make that happen. And I think we have an exciting opportunity ahead of us, and as being a person in the CIHR shop for the moment, developing funding opportunities to move this agenda forward is certainly my passion. Of using both clinical and social platforms, we talked about this, for novel ways of doing research. So whether you're actually using social media and the information that comes from that in order to, which the FDA is currently using to track medications and so on, or you're using clinical platforms to run the studies that you want to run, I think this is just the beginning of something really exciting. So I want to thank you so much for your attention and for just giving me this wonderful opportunity to talk to you. So thank you. I think there's a time for questions.
We have time for a few questions. And we have microphones.
Hi, Robyn. That was fabulous. I really appreciated the very clear and profound nursing lens that you brought to that conversation through the whole, and I think that's often a part that we don't hear as loudly and clearly. And as we evolve here in this community and nationally and beyond to really invest in the IT health universe, what suggestions do you have to ensure that we don't lose that nursing focus in the context of so many other disciplines being very interested in getting into this conversation?
We talked a little bit about this earlier. It's my strong belief that you actually have to attach this to the safety, quality, cost agenda. It has to be very, very tightly connected with that. If you don't tightly connect it with that, what are you trying to accomplish with this? Be very clear on that and pushing that agenda. What are we wanting? Where are we at right now? Where do we want to be? And is this technology going to do it for us? Or what technology do we need to do it for us, if anything, right? So I think that has to be really clear. And we've been very lazy, we as a collective, lazy in producing that thinking process. And I think we're seduced by maybe by vendors who basically are promising you everything will snow in July here, just press that button. You know, I think we've been seduced by that. And we just have to put our thinking hats on and say we have to make sure that that's aligned. And I think the issue here is at the top leadership. The top leadership is old people like me who basically don't necessarily know the business. They're swayed and seduced by the silver bullet promise. And we have to just stop doing that. That's just not going to work. And as you try to do more and more clinical implementations where you're at the front line and you are actually trying to put something in the front line, and there's been a number of very sad, had to pull it back because it killed patients. Okay, so we cannot afford to do that. So I think it has to be driven very much by the safety, quality agenda, what are we trying to achieve? And as soon as you get that on the conversational palette as the driver, then nursing has to be there, right? Because they are going to be delivering that, and they are the ones that are going to say, what do we need to do for safety and quality? They're going to have to say that. So I've had the same kind of frustrating experience I'm sure you have in actually trying to talk this through. And I realized in retrospect and looking back, is because it wasn't attached to that. It was its own divorce thing over in the IT department, doing its own thing, you know, unrelated to anything else. That we can't do. There's probably refreshments outside.
There are. So
thank you very much.
Take the opportunity for further conversations with Dr. Tamblyn later. Thank you very much.
Thank you.
Yes. Don't go away.